All right, we're back again. We're doing some more Gastro Med questions. Let's see if we can get any of these answers. Starting off strong and heavy with a 45-year-old obese man, type 2 diabetes, reviewed in clinic. He is well and asymptomatic. Annual blood tests show slightly abnormal liver functions. There's a gander, Billy's a bit up, ALP, ALT, both a bit up. Gamma, GT, that looks normal. Albumin is fine. He's having an ultrasound. That sounds like a normal thing to do. Standard liver screen bloods. Alcohol is within recommended limits, including viral serology. What else do we need to do? Right, so we know that he has type 2 diabetes, LFTs are a bit normal, and he's otherwise fine. He's already had an ultrasound, so I don't think an endoscopic one will be necessary. Blood enhanced fibrosis liver blood tests. I'm pretty sure there's some screening calculations to calculate a fibrosis score, but can't really remember. Repeat liver ultrasound. I've not seen anyone do that, so I don't think that's the case. Liver biopsy seems pretty strong, seeing as he has got no other symptoms and the LFTs are only slightly deranged. This is likely going to be non-alcoholic fatty liver disease, so I don't think we jump into biopsy straight away. I'm keen on this other blood test to assess the sort of fibrosis level. God knows, let's see. All right, non-alcoholic fatty liver disease, enhanced liver fibrosis testing. Okay, so that's what we have there. That's pretty straightforward. Did they say anything about this? Dietary restriction? Nope, fine. On to the next one. We love these vignettes, they're nice and short. Which one of the following is a risk factor for gastric cancer? Each one is a risk factor for gastric cancer, except I really don't know. Smoking is a risk factor for everything. Pernicious anemia? How is it a risk factor? Is it cause or effect? Probably got something wrong with those chief cells, so let's say yes. Blood group A, duodenal ulceration. I don't think blood group A. It doesn't seem... Hey, you know what? I actually did that completely by mistake. I had it in my head that I went through the risk factors and then I was thinking, actually, I think this one is more likely to cause cancer, and that's why I clicked on it when I was about to click on A. Sometimes this happens when you are wrong enough to be correct, and we will take those when we do. A 31-year-old woman presents with symptoms consistent with celiac disease. Which one of the following tests should be used first line when screening patients with celiac disease? These are the TTAGs. We're not thinking these other ones. I feel like some of these used to be used. Maybe these ones used to be used. I feel like I remember those. I feel like these can be used as well. I'm not certain about the others. I'll probably highlight this as gold standard. First line, I only know to do TTAGs. Alright, that's our simple one. What do they say about these weird HLA ones? While approximately 95% of celiac patients carry it, so some genetic testing. That's interesting. And when do you do the antibodies? Very specific, not first line in the testing. Technically more demanding, require indirect immunofluorescence or tissue substrates, making them more expensive and labour intensive than TTG testing. Alright, we'll take those. We like some TTGs. Next. Alright, a 54-year-old man is investigated for dyspepsia. Endoscopy shows gastric ulcer. Clo test is done. Shows Clo test positive. Fine. Has H. pylori eradication. 6 weeks after completing the treatment, he comes into review. Unfortunately, his symptoms have not improved. Right, so what do we think here? We think that he probably still has H. pylori. I know that you have to stop PPIs 2 weeks before. And if you're doing testing again, it needs to be done 4 weeks after. We know that that is going to be the urea breath test. Why do we say urea breath test? We know that the hydrogen breath test is used for small gut overgrowth. It's a test for sort of carbohydrate substrates, so we know it's not going to be that. H. pylori serology, I think, comes back positive. I don't know when it stops coming back positive, or actually, is there even H. pylori serology? I'm just trying to think. I don't think it's that. And a gastric biopsy and stool culture, Biopsy only if you're doing another endoscopy. Would you even consider that? And stool culture, you can test for it in stool, but I'm sticking with what I know. When do they say to do the stool testing? Serum antibodies remains positive after eradication. They haven't given a time there either. And the stool antigen test, okay, is also positive. But it seems like we are going to be doing the urea breath test anyway. Next question. Okay, it's not really 4 out of 4 because I messed up number 2, but it looks that way, so we're doing well. Right, now we have some hepatitis. This should be straightforward. Presents GP with fever and jaundice. Known IV drug user. Doctor has Hep B panel. Results, she currently has hepatitis. IgG and IgMs. Alright, we don't have the serum values. In terms of immune response, we know that IgMs are always first, then followed by IgGs. So this looks like it's a chronic picture, and she's actively infected. So that's why we're thinking chronic Hep B. We haven't got the serum values to talk about immunization, but also this would show that there is a hepatitis infection going anyway. So that seems pretty right. Okay, this is a pretty straightforward one. We're not too angry at that. Next best management for this patient. Right, what have we got? 67-year-old man admitted to Gastro ward, 8-day history of cramping, abdominal pain, fever, diarrhea, opening his bowels up to 6 times a day, past medical history, COPD. He's had 2 courses of antibiotics and an exacerbation to treat an exacerbation in the last 2 weeks. So this man has C. diff. Given the likely diagnosis, he's commenced on a course of oral vancomycin. Lovely. Vancomycin. It's a 10-day course anyway. He's on Vanc. Oral Vanc shows little to no improvement. Switched to fidamoxis. However, he's still got pain, diarrhea after completing the course. Next best management. I know that they do go on to IVs. So they tried the orals. We'll be trying IVs. And I know it's IV Vanc. Or I'm pretty sure it's IV Vanc. I'm trying to think of someone has... I actually saw a guy come in, similar picture to this actually, but he had not been treated at home in the community and his creatinine was 1,800 and his EGFR was like 4. So whilst his diarrhea needed to be sorted out, the man's kidneys were absolutely kaput. They ended up... Yeah, we had to sort him out. I don't know how he ended up on general surgery, actually, because that's where I was working, and somehow he must have just had abdo pain, somehow ended up being referred to us from, I don't know if it was from ED or from DEC or something, but yeah, it was a crazy time. He did have some really brief dialysis to stabilize things. He did go up to ITU, I think just for like a day or 2 to sort out his kidneys, but anyway, that's a tangent. These IVs. Right, I need to do one of these. And I'm pretty sure you double up on the IV. Or a Vanc and IV Met. Fine. Okay, I wasn't sure. First episode, C. diff. Doesn't respond to Vanc or fidamoxicin. Fine. Alright, in my head it was just to throw some IVs at him. In reality, I'd always look things up on the hospital guidelines, but hey, we're not there yet. Right, what are we doing next? Which of the following drugs is used in the management of diabetes mellitus? Which one of the following drugs is used in the management of diabetes is most likely to cause cholestasis? Cholestasis. Okay, which are most likely to mess around with your actual biliary duct flow. Right. So if we just go down the list, we know that metformin. I don't think I've ever heard of metformin causing cholestasis. I feel like sulfonylureas do have... Pretty sure I've got that in my head associated with some sort of jaundice. But acarbose, I think, causes GI upset. Metformin, I think, can cause lactic acidosis as its main thing. I mean, it can cause GI upset as well, but not going to cause cholestasis. Pioglitazone, again, I think it might do something to the liver. I had a gut instinct about the sulfonylureas. Insulin, nah. I think insulin is totally kosher. There we go. We like the sulfonylureas. May cause cholestasis. Alright, We love the dregs of the flashcard memory. Next, let's go. A 32-year-old man, Crohn's disease, presents a GP, pain around his anus, foul smelling, pus being present when he wipes. On exam, discharging orifice seen on his perineum. DRE shows perianal fistula. Manage this. MRI. That's an easy one. I was on Gen Surge. That's what we did. You need to be able to distinguish between the different soft tissues. With that, it would help you plan your operation with how deep you need to go and everything. So, that's fine. Next up, 45-year-old man returns from holiday in Thailand, non-bloody diarrhea. After further questioning, he's had nausea, had vomiting, stomach has been painful with cramps for the past 48 hours. Given this man's presentation, what's his symptoms? It's only been 48 hours. We don't think Crohn's. IBS, very unlikely. Never had it. E. coli, yeah. One of the Campylobacters. It's non-bloody diarrhea, which I think they're trying to say it's not one of the Campylobacters. I mean, I know that you can get non-bloody diarrhea, but I feel like C. jejuni does cause bloody diarrhea, and I think C. diff can. So I think an E. coli, he's a returning traveller, come on. Yeah, you just have to see. Man returns travelling, has the shits. Give him some E. coli. Well, as a diagnosis. What have we got? Any more pearls of wisdom down here? No. Did they say about Campylobacter causing... Does Campylobacter jejuni causes bloody stools? Okay. And C. diff, they're just saying profuse diarrhea. Fine. Alright, we're happy with that. Alright, and question number 10. Let's finish this bad boy up. Alright, let's hit a 90%. Let's get this one right. 51-year-old man presents with dyspepsia intermittently over the last few months. He denies any symptoms of bleeding, dysphagia, weight loss, does not drink alcohol, normally feeling well. He's not on any current repeat medication and has only been taking acids over the counter to help with his symptoms. Exam is normal. Should you recommend? This man should have a bit of 20 mg. That is my opinion. I don't think just for some dyspepsia, given that he's had no bleeding, dysphagia, weight loss, so no trouble in swallowing, he's just presumably a bit of epigastric pain, maybe related to eating. If he did have any red flag symptoms, we'd send him for a bit of an endoscopy whilst treating with a, well, would we give a PPI and then refer? Don't know what the wait list would be like, but anyway, in this situation, 51-year-old man, would we send him off some occult blood testing? I mean, he's not got any other symptoms. I'm trying to think the age that they do send everyone fit test in the UK. I feel like 51's a bit young, but anyway, PPI. There we go. Yep, okay. They're talking about it's not indicated for the fecal occult blood test. Endoscopy would not be appropriate because there's no alarm features. Okay, endoscopy should be considered if they have persistent symptoms despite an adequate trial of PPI therapy. Okay, I think that'd be pretty fine. Hey, that's 10 questions. That's 2 wrong, although it says 1. Let's jump in cock.